Hello everyone, welcome to this next module on respiratory system. Now, this module is about a topic which is very important from the critical care point of view. So, this topic is an acute respiratory distress syndrome, ARDS. Okay, this is a very important topic because this is such a common case in your intensive care units, and a proper recognition of this entity, that is ARDS, is very essential, and you have got to pick it up early also and start the appropriate management. Okay, so let's see this important topic, ARDS, acute respiratory distress syndrome. So first of all, let's try to understand what is this ARDS. Okay, what is this entity? ARDS is an entity where you have got it's a syndrome, okay, acute respiratory distress syndrome. So it is some syndrome in which you have got an acute respiratory distress, correct? Putting it in very simple terms. So this entity is nothing but an acute onset, okay, an acute onset severe dyspnea, okay, it's a clinical syndrome characterized by acute onset severe dyspnea. And when you do the ABG, arterial blood gas analysis, you will find that this patient has got a hypoxemia. And when you go for a chest X-ray or a CT thorax, you will find that the patient is having diffuse pulmonary infiltrates. Diffuse pulmonary infiltrates. And again, if not appropriately identified and managed, this can lead on to respiratory failure. Okay, so that is the entity of ARDS. Okay, now having understood what is this entity, let's try to see why this happens, why this distress, why this lung problem. Okay, so we are going to see the why of it. Now, this particular term, okay, the ARDS was previously also coined as acute lung injury. Okay, so there is some injury to the lungs. Okay, that was the previous term of ARDS, acute lung injury. So to have a lung injury, the injury can either be a direct injury or an indirect injury. Okay, either you can have a direct or maybe an indirect injury. So what are the ways in which your lungs can be directly involved? Okay, so maybe there is some infectious process like pneumonia. Okay, he has got some infectious process like pneumonia. Or maybe he has probably aspirated the gastric contents right to his lungs. Okay, so there is some aspiration of gastric contents. Aspiration of gastric contents. Okay, suppose there has been some near drowning. Okay, he has got some drowning. Okay, or maybe there has been some pulmonary contusion, or maybe even a toxic inhalational injury. Toxic inhalational injury. So these are the direct injuries that can happen to your lung, okay, which can result in ARDS. So what are we learning now? We are trying to learn the causes of ARDS, which can be due to a direct lung injury or indirect lung injury. So indirect lung injury can be because of sepsis, and always remember this one is the most common cause of ARDS. Okay, most common cause of ARDS. So you can have in sepsis, you can have in case of trauma. Okay, you can have in case of burns. Okay, maybe as a part of multiple massive blood transfusions. Multiple massive blood transfusions also can cause an indirect lung injury. Maybe drug overdose can cause. You can have it as a part of pancreatitis. Okay, and also post CABG, post bypass grafting also you can have ARDS. So the lung injury in case of ARDS may be either a direct lung injury or an indirect lung injury. So remember, most common is sepsis. Okay. All right. So these are the causes of ARDS. Okay. Very clear. Now, having understood the etiology of ARDS, what are the possible causes leading to ARDS? Let's see how this direct and indirect lung injury, okay, about these causes, how they result in the various pathological change in ARDS. Okay, so let's try to see that. So we are trying to see the pathogenesis. Okay, you are trying to see the pathogenesis. Etiologies we have just seen. What about the pathogenesis? Now, pathogenesis of ARDS. See, the ARDS actually progresses through certain stages. Okay, there are certain stages through which it proceeds. 3 stages, in fact, 3 pathologic stages. Okay. Now, the 3 pathologic stages are, these are not clinical stages, these are pathological stages. So, because we are trying to see what is the pathology that is happening. First, you have got a exudative stage. You have got a exudative stage. Next, you have got a proliferative stage. Proliferative stage. And the final one is a fibrotic stage. Fibrotic stage. Now, these are the pathologic stages in case of ARDS. Now, I'll try to explain it for you. For the time being, remember the name of these stages. Now, the first stage, exudative stage. Okay, this usually is lasting from, that is, from day 1 to day 7 of the illness is usually roughly the exudative stage, and from day 7 to day 21 is when you have the proliferative stage, and beyond 3 weeks you have the fibrotic stage. Okay, that is the natural course of the disease. Okay, you can say that this is the natural course of the disease, the exudative, proliferative and fibrotic stages. So let's come to the pathogenesis proper. Now I've taken this very nice picture from Harrison, which actually summarizes everything about ARDS. Such a good picture. They have given a comparison between the normal alveolus as well as the injured alveolus during the acute phase of ARDS. So when I say acute phase of ARDS, I predominantly mean the pathological corresponding stage is the exudative stage. Okay, that is the acute stage. Okay, that is day 1 to day 7. Now, in the normal alveolus picture, let us try to appreciate that there is a surfactant layer. You have got an epithelial basement membrane. The alveolar epithelial cells, you can have type 1 epithelial cells, type 2 epithelial cells, and you can see you have the pulmonary alveolar macrophages. You see this is air inside the alveolar space, and you see here you have got a interstitium, you have got endothelial cells here. This is the blood vessel, endothelial cells. There is an endothelial basement membrane, and you see the RBCs are flowing through this. Okay, so that is the point I want to tell you is normal individuals. Okay, to begin with, normal individuals have a intact alveolo-capillary membrane. You agree with me? Intact alveolo-capillary membrane is what every normal individual has. And when you have an intact alveolo-capillary membrane, you will never have any of your RBCs or the fluid going into the alveoli, which is why normally your alveoli as well as the interstitium is kept very dry. Okay, normally it is your alveoli is not a fluid filled compartment, correct? So because you have a very tight alveolo-capillary membrane, okay, which prevents, which only allows the gas exchange, and you will not have any leakage of your proteins, RBCs, inflammatory cells. Okay, so that is normality. So now let's see the abnormality. Whenever there is a ARDS, a direct or an indirect lung injury, what happens is that this alveolo-capillary membrane, which was very intact, that is disrupted. So it begins, the pathogenesis begins with injury to the alveolar epithelial cells, injury to the alveolar epithelial cells, which are predominantly the type 1 pneumocytes, because you have the type 1 and type 2 pneumocytes. So predominantly it is the type 1 pneumocytes that receive the injury. And you also have an injury to the capillary endothelial cells. Okay, injury to the capillary endothelial cells. So alveolar epithelial cells and capillary endothelial cells, they are injured, and that will indirectly cause or maybe directly cause what? A disruption of the integrity of alveolo-capillary membrane. Okay, there is a disruption of the integrity of alveolo-capillary membrane. So that is what happens. Okay. Now, when such a disruption of the integrity happens, there occurs leakage of substances. Okay, till then, there was a tight compartment just allowing the diffusion of gases. But now there occurs exudation. You remember the first stage was exudation. So in this part of the picture, you get an exudation. So the alveolar, the capillary endothelium, you can see there is a swollen and injured endothelial cells. And also the alveolar epithelium is also injured. You can see the type 1 cells are becoming necrotic, and the type 2 cells are relatively preserved. Okay, and when such a injury happens to the alveolo-capillary membrane, what will happen? You will have your RBCs which are entering your alveoli. You will have fluid which contains protein reaching your alveoli as well as the interstitium. So you will have fluid in your alveoli and fluid in your interstitium. What sort of fluid? Fluid containing proteins. So you see there is a protein-rich edema fluid in your alveoli, and you see there is a widened and edematous interstitium. There is fluid accumulating in the interstitium also, and you will have the inflammatory cells like your neutrophils. Okay, again entering into the air spaces. You can have it in your interstitium as well. So in your interstitium and alveoli, what will happen in short? Because of the disruption of the alveolo-capillary membrane, there occurs what? Alveolar and interstitial inflammation. Alveolar and interstitial inflammation. And what will be there? You will get a protein-rich fluid, plus you will get all these inflammatory cells. Now what happens is that when there is inflammation ongoing, you remember your macrophages. Okay, you remember the macrophages. So these macrophages will secrete certain cytokines. Okay, you will have secretion of interleukin 1, interleukin 6, interleukin 8, TNF alpha. So macrophages in association with the inflammatory cells which are present in the alveoli will secrete certain cytokines. Now these cytokines will again cause the recruitment of the inflammatory cells from the capillaries to the interstitium and alveoli. Okay, so they will further increase inflammatory cell recruitment. Okay, and then what happens? You see here, this blue cell is the macrophage. You can see the IL-6, IL-8, TNF alpha, all these cytokines, and you can see other cytokines also released by the neutrophils. You can have the leukotriene B4 release, LTB4. Okay, leukotriene B4, other cytokines, your platelet activating factor, oxidants, proteases, all are released, and these will again cause destruction of your alveoli, the alveolar epithelial cells, the endothelial injury will be there. Subsequently, it triggers the cascade of inflammation in a ARDS. And what results is that in addition to the epithelial injury, which can be in the form of a bronchial epithelial sloughing, a necrotic type 1 epithelial cells. In addition to this, there can be a dysfunction of the surfactant as well. Okay, you will get a dysfunction of the surfactant. So when you have a dysfunctional surfactant, now the surfactant is very normally in normal individuals. This surfactant is very important to prevent alveolar collapse, especially during expiration. So whenever there is a dysfunction of the surfactant, that can predispose to what? That can predispose to alveolar collapse. That can predispose to alveolar collapse. Okay. So this is what happens in your inflammatory stage or the exudative stage, I should say. Okay. So are you very clear on what are the sequence of events that happen during the exudative stage of ARDS? So that is what happens in all these 7 days. And we will see in a short while what effect does this have on the gas exchange. But as of now, you know about these inflammatory cells, the RBCs all getting into the alveoli. And there is so much of alveolar flooding. Okay, it's too much of fluid, RBCs, proteins, everything in the alveoli. And even this protein accumulation plus your dysfunctional surfactant can contribute to the formation of hyaline membrane. Okay, that can contribute to the formation of hyaline membranes. What contributes? The protein accumulation inside the alveoli plus your dysfunctional surfactant leads to hyaline membrane formation. Now this happens during the exudative phase. After the first 7 days, the next stage is called a proliferative stage. Now proliferative stage is again a active stage, but probably this is the stage where some sort of a disease resolution starts. Okay, the disease resolution is starting. Disease resolution begins. So I'm not saying that the disease has become quiescent. The disease is still active. The patient is still symptomatic. But there is some sort of a resolution that begins, because you remember the alveolar exudates in case of the exudative stage. So they begin to more or less organize. Okay. So before, too much of exudates, but now they are beginning to organize. And in the stage 1, that is your exudative stage, you had a neutrophil rich inflammatory fluid. Okay. So neutrophil rich inflammatory fluid was there in your the first stage, that is your exudative stage. Now it transforms to a lymphocyte rich fluid. Okay. So now it transforms to a lymphocyte rich fluid. So that is what happens. The disease is still active. There are inflammatory cells, but neutrophils going to the lymphocyte lineage, the cells are replaced by the lymphocytes, and then you will have organization of the exudates and some sort of a disease resolution that begins is called the proliferative. Now the third stage in the disease course is fibrotic. Now remember, it is not necessary that each and every patient with ARDS will go to the fibrotic stage. It's not necessary. Fibrotic stage means that there is some activation of your fibroblast. Okay, there is fibroblast activation. And because there is a fibroblast activation, there is a recruitment of these fibroblast and the cytokines which cause collagen deposition, which can trigger fibrosis. Okay. Now it is again not necessary that this sets in, because if you treat aggressively early, you will not have this change. But once this fibrosis sets in, what happens is that there occurs structural changes in the alveoli. So the alveolar, as well as to some extent in the larger airways, there occurs structural changes. So when your structural change occurs, it is almost going to the stage of a irreversible injury, where the alveoli are very much fibrosed and very stiff. Okay, so the compliance is affected. So that happens in the fibrotic stage. So you do not want your patient to go to the fibrotic stage. Okay. So these are the stages of, or the pathological stages of ARDS. Very clear? Okay. Now, after having understood that, just let me tell you one thing. Again, just to summarize the exudative and proliferative stage, maybe I'll first show you a timeline here. Okay, yes. So you've got a exudative stage, a proliferative stage, and a fibrotic stage. Exudative stage predominantly characterized by edema and hyaline membrane formation. Remember that I told you can have alveolar and interstitial inflammation in ARDS. Now let me again remind you that this interstitial inflammation predominates in the proliferative stage. In the exudative stage, it is the alveolar inflammation that predominates, and in proliferative stage, you will have the interstitial inflammation. That is why I told you, even in the proliferative stage, the disease process is still active. And then it goes to the fibrotic stage beyond 3 weeks. Very clear? Okay. And just to understand again the timeline of events, you see here there is a exudative stage here, a proliferative stage here. Okay, the first 7 days is the exudative stage. You can see the edema and hyaline membrane, and in the proliferative stage is where the interstitial inflammation, and then the interstitial fibrosis is trying to come to the picture. That's what happens. So tell me now, are you very confident about your understanding of why ARDS occurs, or what is the sequence of pathological events in ARDS? I hope it is crystal clear with that diagram. Okay. All right. So we have understood the pathogenesis, etiopathogenesis. Up next, what are we trying to learn? We are trying to learn the gas exchange abnormalities in ARDS. Okay, what are the gas exchange abnormalities that occur in ARDS? Okay, let's try to see that. So you know that in case of the ARDS, especially the exudative phase, there occurs alveolar flooding. So your alveoli is being flooded with inflammatory protein-rich fluid. So which means there will be a diffusion abnormality across your alveolo-capillary membrane. Okay, there will be diffusion abnormality. Now when there is a diffusion abnormality, whatever air is reaching the alveoli, it is not able to pass and reach the capillary side, because of which what will happen to the PaO2? Your PaO2 will be decreased, or you will have hypoxia. Okay, there will be a hypoxemia. Okay, decreased PaO2. Now, when there is a decreased PaO2, there is a hypoxia, there is a hyperventilation, the patient will expire at a faster rate. And when there is a hyperventilation happening, what will happen is that there will be a carbon dioxide washout, and because of which you will get a normal or maybe a decreased PaCO2. If there has been a good amount of washout, then definitely your PaCO2 will be decreased because of the carbon dioxide washout, and early stages you will get what? Respiratory alkalosis. Respiratory alkalosis. And what will happen to the AA gradient? AA gradient, that is your alveolar arterial oxygen tension gradient. The gradient will increase because in your arterial side, capital A is the alveolar oxygen and small a is the arterial oxygen. So arterial oxygen is very much less because there is a diffusion problem that is happening. So the gradient will increase. There is an increase in the alveolar arterial oxygen tension gradient. Okay, so these are the gas exchange abnormalities that occurs in ARDS. So you tell me, what sort of respiratory failure is likely to happen here? It's a diffusion problem, and this is a hypoxia without a hypercapnia. So if you have watched my respiratory failure module, I have discussed it there. This is called a type 1 respiratory failure. This has got a type 1 respiratory failure. But if you ask me, Is type 1 respiratory failure the only type that can occur in ARDS? My answer is no. Because if it is untreated, if it goes to the later stages, then there can be a ventilation problem, so much so that the patient can go for a type 2 respiratory failure as well. But if you are asked what is the commonest type of respiratory failure in ARDS, your answer is going to be type 1 respiratory failure. Okay. Now, along with this changes in the oxygen tension, your decreased PaO2, decreased PaCO2, you can have changes happening in your pulmonary vasculature as well. Okay, you can have pulmonary vasculature changes as well. So, what is the vasculature change? See, you've got a hypoxia here, and we have learned, I've discussed in the previous other modules also, when you have a hypoxia, what is the response of the pulmonary vessels? There is a pulmonary vasoconstriction. So there is a pulmonary vasoconstriction. Okay. And this can lead on to pulmonary hypertension as well. Okay. So there is a pulmonary vasoconstriction also happening in ARDS. So it can affect the vasculature as well, your pulmonary vasculature as well. So are you clear with the gas exchange abnormalities in case of ARDS? Pakka, are you conceptually clear on what happens? Yes? Shall I move ahead? Okay. Now, having understood ARDS, what is happening here, let's try to come to the diagnosis. So let's try to diagnose ARDS. Okay, we have understood the etiopathogenesis. See, diagnosis of ARDS, first of all, you have got to have a clinical setting of ARDS. Okay, you have got to have a clinical setting of ARDS. Now, when I say clinical setting, I mean that somebody has got evidence of probably a direct or an indirect lung injury. We have already discussed the causes. So, there should be a clinical setting for the ARDS, and the patient should have an acute onset dyspnea. He should have hypoxemia. Okay, there should be on the X-ray, you should have bilateral lung infiltrates, and the patient can go in for respiratory failure. So the criteria, okay, what is the criteria by which you will diagnose ARDS? The criteria is referred to as the Berlin criteria. Okay, it is referred to as the Berlin criteria. And this Berlin criteria for ARDS subdivides the ARDS to mild ARDS, moderate ARDS, as well as severe ARDS. Mild, moderate, severe. 3 types. Now let's try to see what is this mild, moderate, severe. Let's try to see our Berlin criteria. So let's see this from Harrison, a simple one. Okay, it is dividing it into mild, moderate, severe. So that is, the division is based on the oxygenation. Okay, you take into account your PaO2 to FiO2 ratio. Okay. Now, what is the significance of this ratio? See, PaO2 is your arterial oxygen, correct? And FiO2 is the fraction of inspired oxygen. Okay. Now, what happens is that in ARDS, how much ever you try to increase your fraction of inspired oxygen, do you think this oxygen will translate to your partial pressure in the arterial side? No, because there is some diffusion abnormality happening. So what do you say? What will happen to this ratio? This ratio will be decreased. Why it is decreased means corresponding to an increase in the FiO2, you will not have an increase in your PaO2. Okay. So there will be a decrease, and you can classify it based on this decrease into mild, moderate and severe categories, this ratio. So if your PaO2 by FiO2 ratio, if it is between 200 to 300 millimeter mercury, okay, in such a case it is mild. If it is 100 to 200, it is moderate, and less than 100, it is going to be severe. Okay, as you can see here, there is a mild, moderate and severe. So you can see that the PaO2 by FiO2 ratio that is being used to classify it, mild, moderate, severe. Now remember this entities, this PaO2 by FiO2, this is actually calculated when the peak is more than 5 centimeter water. Okay, so you keep the PEEP at more than 5 centimeter, and that is when you estimate the PaO2 by FiO2 ratio. Okay, all right. So why do I say that the PEEP has to be above 5 means? See, in ARDS, we saw that the alveoli are filled with some fluid, and along with that, we also saw that there is some surfactant loss. So when there is a surfactant loss, I told you that will result in alveolar collapse. So alveolar collapse mainly occurs in what stage? Is it inspiration or expiration? Expiration. So if you do not keep your PEEP high, okay, if you do not keep your PEEP high, then what will happen is that towards expiration, your alveoli will collapse. Okay, so the peak end expiratory pressure, okay, it has to be maintained above 5 so that the alveoli are not collapsing in the expiratory phase. Otherwise, you might not be able to make a correct calculation. So the calculation is made for a PEEP more than 5. Okay, and yes, in the criteria it has got to be an acute onset. That is, the symptoms happen within 1 week of the trigger, which may be a direct or an indirect lung injury. And the chest x-ray is showing bilateral infiltrates. Okay, and very, very important, you have got to differentiate it from a cardiogenic cause. Okay, it should not be a infiltrate, chest infiltrate, because of a increase in hydrostatic pressure, as occurs in case of your pulmonary edema because of a cardiac cause. Okay, remember that this ARDS is a classical example of a non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema. Okay, which means that you should never confuse this with a cardiogenic pulmonary edema. See, the criteria is defined such a way, because if a patient who is having a coronary event, okay, an acute myocardial infarction, he might develop a pulmonary edema, and you might find diffuse bilateral infiltrates in a bat wing type of manner. So if you see such an infiltrate, do not think that any acute onset breathlessness with a bilateral pulmonary infiltrate, okay, is a cardiac or is an ARDS cause. This can very well be a cardiac cause, which is again more common. Okay, so you should rule out, in the diagnostic criteria itself they are saying that you should rule out any evidence of left arterial hypertension. So in the previous version of this criteria, they had used the pulmonary capillary wedge pressure also, which is not included in the current criteria. It is just that the previous criteria said that the pulmonary capillary wedge pressure should be less than 18 millimeter mercury. You know that the pulmonary capillary wedge pressure is an indirect indicator of your left atrial pressure. So usually you know that when the left atrial pressure is above 18, this could very well be because of a left ventricular failure resulting in a pulmonary edema. Okay, so you have got to rule out your hydrostatic causes, that is an increased hydrostatic pressure, as can occur in case of your cardiac failure. Okay, so that is how you will diagnose ARDS. So okay, so mild, moderate, severe, it is 300 to 200, 200 to 100, and then again less than 100, that is your severe. Okay, so that is the criteria for ARDS. Always remember, please exclude cardiac cause. That is why I started off like this. To diagnose ARDS, there should be a setting of ARDS. A patient who is perfectly fine now, who comes to the emergency with some chest pain and some respiratory distress, cannot be ARDS. Okay, so there should be a clinical setting of a ARDS. Very important. Now just let us see the X-ray finding of ARDS. As you can see here, I've taken this picture directly from Harrison. This is a bilateral diffuse pulmonary infiltrates. Diffuse pulmonary infiltrates. Now one point of difference is that in case of your non-cardiogenic pulmonary edema, you are not going to find any cardiomegaly, because usually in cardiogenic pulmonary edema, you are likely to find some cardiomegaly. Unless it is an acute myocardial infarction, If it is some, say, dilated cardiomyopathy or some cardiomyopathy producing a pulmonary edema, you're likely to get a cardiomegaly as well. Okay, maybe somebody who has had a previous acute MI. Okay, maybe 2 years back he had an acute coronary event, and then after that there was some ischemic dilated cardiomyopathy developing in that patient. So now he can present with an acute pulmonary edema. Okay, so that is going to be a cardiogenic pulmonary edema, and you will have a dilated heart. But in case of an acute cardiac event, okay, now he has developed a acute MI, probably you are not going to get your cardiomegaly. But again, it will help you to differentiate a cardiac from a non-cardiac pulmonary edema in certain scenarios. So you see here bilateral diffuse pulmonary infiltrates. You can see the CT thorax also showing diffuse infiltrates. Okay, now remember that this entity ARDS, the pathology is very much heterogeneous. Okay, the pathology is very much heterogeneous, which means though you say, I'm showing the histopathology of a patient, okay, autopsy specimen of the alveoli in a patient who died with ARDS. So this is a diffuse alveolar damage that has occurred. So yes, it is correct that there is a diffuse alveolar injury, but there may be some alveoli that are spared also. It is not like every time the whole lung can be involved. So sometimes some alveoli may be spared. So it is a heterogeneous pathology that occurs. Some of the alveoli may be collapsed because of the surfactant loss. Some of the alveoli will be dilated with this edema-rich proteinaceous fluid. Some of the alveoli may be normal. So it's a heterogeneous pathology that happens. Okay, are you very clear? Okay, so now we have understood the entity, why is it occurring, as well as we understood the gas exchange abnormalities. So you understood a patient who is likely to have ARDS presenting to your emergency. Now let us come to the final aspect about the treatment of ARDS. How are you going to treat ARDS? Okay, this ARDS has got other terms also, just like the term I mentioned. It is also referred to as a diffuse alveolar damage. And I told you previously it was also called acute lung injury. Okay, so current accepted terminology is ARDS. Now management of ARDS, again let me tell you one thing. The most important aspect in the management of ARDS is mechanical ventilation. Okay, is mechanical ventilation. This is very, very important. This is in fact the cornerstone in the management of ARDS. Now, when you want to manage ARDS, definitely you have got to treat the triggering cause, because sometimes it might have been a pneumonia which triggered a ARDS, or maybe some sepsis that has triggered, or maybe pancreatitis, so maybe burn. So it's very important that along with treating your ARDS, along with taking care of the airways, you've got to take care of the triggering cause as well. Now, I told you mechanical ventilation is the most important aspect. So about mechanical ventilation, there are different strategies which have been proposed for mechanical ventilation in ARDS. Now, out of all these strategies, the most important one in ARDS, which has the best results, is a low tidal volume ventilation. Okay, which is very, very important. Low tidal volume ventilation. Now, what do I mean by low tidal volume ventilation? It means you are trying to, the tidal volume should not exceed 6 ml per kg. Okay, it should not exceed 6 ml per kg. So you are trying to maintain it around 6 ml per kg, okay, not beyond that. So what happens is that, what is the problem if you go for a higher tidal volume ventilation? That is what you have got to understand conceptually. Now, everyone, listen to me. I told you just a while back, ARDS is a heterogeneous entity, correct? So in which some alveoli are normal, some are having collapse, some are filled with fluid. So when you give tidal volume, see, suppose you have a alveoli which is collapsed. I agree that you would need the airway to be maintained, and you would need a good amount of tidal volume. I agree with that to open up the airways. But What about the airways which are normal? Because the same air that you are giving to the diseased lung, you are giving to the collapsed lung as well as the lung which has fluid as well. So there is a good chance that if you give a high tidal volume, okay, the problem with a high tidal volume is that you may get something that is known as volute trauma. Okay, that is the trauma induced by the tidal volume, especially to the normal alveoli. Okay, to the normal alveoli, there can be a volute trauma. Okay, that is very, very important. Okay, yes, there is problem on the other hand. You have the atelectasis, and there is an entity known as atelectic trauma. Atelectic trauma. Okay, there is a trauma suffered because of your atelectasis and collapse of your airway. So what you do is that you go for your low tidal volume ventilation so as to prevent the volute trauma, and so as to prevent the atelect trauma, you give the patient a higher PEEP as well. Okay, so a higher peak end expiratory pressure also, so that the alveoli does not collapse at the time of expiration. You remember the problem because of the surfactant loss, alveolar collapse. So these two strategies are very important. Okay, out of this, the most important one I would say will be the low tidal volume ventilation. Yes, your high PEEP is also very important, and you can also go for a inverse ratio ventilation, whereby you are trying to prolong the duration of inspiration. Okay, so you are trying to keep your inspiration time more, so that your alveoli does not collapse, because it is in the expiration that if you keep the expiration time more, the tendency of the alveoli to collapse also will be more. So you give the inverse ratio ventilation where you try to increase the time of inspiration. Okay, that is called inverse ratio ventilation. So previously there was another strategy that was used, that is referred to as the high frequency ventilation. But at present, this high frequency ventilation has gone out of favor. So at present it is shown that it is not having that much of a benefit. Okay, so the most benefit is with low tidal volume ventilation, high PEEP as well. And in cases, you can also go for your ECMO, that is your extracorporeal membrane oxygenation, which would work like an artificial heart lung. Okay, similar to that it would work. So you will go for your ECMO, or you can even go for a early neuromuscular blockade as well in such patients. Early neuromuscular blockade as well. Well, the role of steroids again is controversial. Usually we do not give steroids. Okay, usually they are not preferred in case of ARDS. Okay, now I'll just show you one table in Harrison which actually shows you the evidence-based recommendations for ARDS. I just wanted to pick up one MCQ from this. There are lots of strategies adopted. You can see the recommendations are there from A to D. A means the best recommendation. D means it is not of use. Okay, so A you can see, which is the only one which has level A recommendation, is low tidal volume. Yes, high PEEP is important. Minimize left atrial filling pressure. And another point that you should learn along with these strategies is that in ARDS you can go for something that is known as your prone position ventilation. Okay, you can go for your prone position ventilation as well. So if there is adequate expertise in performing a prone position ventilation, that is in the prone position, so that again has been shown to have a level B evidence, so which is in fact a relatively good evidence. Okay, A is the best evidence. And you see here high frequency ventilation, it is D, which means it is not of much value. Previously it was said that okay, high frequency may have some benefit, but no. You can go for ECMO, early neuromuscular blockade, and you can see glucocorticoid treatment, not of much benefit. You can try your inhaled vasodilators of some benefit, and surfactant replacement therapy. See, I told you there is some surfactant dysfunction happening. So, but again, the surfactant replacement therapy again is not shown to have much benefit when you replace the surfactant. So, all in all, the message is very clear. ARDS is a very, very important entity from a critical care point of view. Remember, mechanical ventilation is the cornerstone of management. Go for low tidal volume ventilation, high PEEP. What exactly is the value of PEEP to be maintained? That is not mentioned in the guidelines. They have not made such a recommendation in any of the guidelines, but you try to keep the PEEP high. Third is you can also go for a prone position ventilation, but you will not favor a high frequency ventilation now. Also, there is not much role for steroids or artificially replacing the surfactant. So I hope this topic is crystal clear to you. And always remember, along with this management which I have mentioned, please try to treat the precipitating cause as well. All right.